Over to you, Emile.
Yeah, thank you. Okay, so welcome everybody. There's going to be a lot of economics today. So I'm not sure how many of you have economics backgrounds, but I'll try to make it approachable for a broad audience. Do stop me if you want clarifications on any of the constructs or methodologies that I'm describing. Hopefully, I think it's going to be approachable. But anyways, and this is a bit of a misnomer, the title actually. We're actually only looking at 5 EU countries, but they are rolling it out across the EU. Currently, 3 other countries have used our methodologies to calculate their economic burden of work injury and illness as well. So a number of us involved in this, myself, Amir Mofidi, he's my partner in crime, he's the other key IWH person who was involved in this, and a number of us also from the TNO in the Netherlands, and VVA, which is an Italian consulting firm that was a key player in getting us a lot of good data. So just the different people involved with the different organizations. The TNO group, they are the lead on the project in terms of they manage the project. We did a lot of the methodology part of it, and then the VVA group, the couple of gentlemen here based in Germany, but it's an Italian consulting firm. They were collecting the data from the different countries that we were focusing on for this study. So this is just a summary of what I'm going to go through over the course of the next 45 minutes or so. I'll try to leave about 15 minutes for discussion, but I'm going to have to go at a reasonably steady pace, so only clarification questions as I go along. So just as by way of background for getting people up to speed, you may be familiar with burden studies. They're often cited in the media, but in case you're not completely comfortable with the framing of them, these studies really measure the total cost of oftentimes a particular health condition. You'll often see studies about the economic burden of lung cancer from smoking or something like that. We did one on asbestos-related lung cancer and mesothelioma recently that used these methods as well. So it may be looking at a health condition, it could be injury, illness, diseases, and it's usually taking a societal perspective. So it's really looking across all the stakeholders that might be impacted by this particular health condition, whether directly, indirectly, and all kinds of spillover effects as well. So we're really considering treatment costs. So those are maybe considered the most direct and obvious cost related to a particular health condition. The healthcare expenses incurred by the healthcare system. There might be other services provided, and productivity is another big aspect that's considered in these studies as well. They're sometimes described as indirect costs. And then what we've actually done, and some studies have started to do, is include the value of lost healthy time as well, sort of thing. So that's sort of a new iteration, a new generation of these studies. They really don't tell you about how to address the issue. So they're not considering treatment paradigms that or prevention initiatives that might alleviate those costs. They're really just giving you a first level piece of information to tell you, well, how much is this burden? What's the magnitude? And so give attention to the fact that if the magnitude is quite large, that it warrants addressing through some prevention mechanism or through some treatment paradigms if it's a healthcare condition that may be treatable within the healthcare system. So it really tells you what the opportunity costs were. If we did address the issue and we could alleviate those burdens, this would be the savings to society. So they provide insights about the magnitude, as I mentioned. They can be used to monitor how burdens change over time. So in particular with our study, one of the plans is going forward is that the countries will be doing these studies on a periodic basis to see, are they doing a better job of reducing work injuries and illness burdens at the societal level? And if they are, you would see those costs going down over time. Every time they do the study, you would expect to see lower economic burdens related to work injury and illness. They can be compared across countries or over time. You can look at different health conditions within a kind of area of work injury and illness to see which burdens are largest in terms of certain types of conditions that warrant addressing because the burdens are quite large. And another key part people sometimes don't realize that the first stage in doing economic evaluation, so the case costing that you can get from these studies, is a really key input into economic evaluations of prevention initiatives related to this. And that's the direction we're taking some of our work in this area as well, is using that case costing to then consider the cost benefit of prevention initiatives. So some of the policy responses might be just increasing funding to intervention options that are known to reduce that burden. In some cases, as I mentioned, the case costing helps. In some cases, there might not be ready answers of how to treat those conditions or how to prevent them, so there might be some research needed. So if there's quite a substantial burden, that might be an incentive for governments or funders to provide funding for academics to do investigations into how to address those issues. So the type of burden that we're undertaking, economic burden that we're undertaking in this study is called an incidence costing study. So what we are doing in our study is considering only newly identified cases of work injuries or illness in a particular reference year. And in our case, the reference year is 2015. And what we do when we identify cases, we look at the lifetime cost of each of those cases. So if it's an enduring condition that has a permanent impairment, if it's a premature fatality, we would consider the cost over the entire expected normal lifetime of that individual if they had a normal life and a normal health profile. So the key question that we're asking in this study then is, what would be the savings to society, in this case a particular country, if we did not have work injuries or illnesses in that particular reference year? So it's an ideal thing. If we could completely eliminate work injury or illnesses, what would society save across all of the different stakeholders who are affected by that work injury or illness? So what we're really thinking about is a counterfactual world. Obviously, the cases that we're looking at 2015 have happened. So we're looking at a scenario as if we didn't have those work injury or illnesses, what would society look like? What would be the benefits to society? And we're really thinking about the current world versus that ideal world and that difference between the two scenarios. So,
your view of the current world.
Yeah, yeah. This is Australia here. Okay. So, and then another thing I really want to point out is that what we're doing is different than accounting. A lot of times people think that I'm doing accounting kind of work or some kind of ledgers kind of type of exercise. But it's very different what economists do. We're really thinking about social values, the things that we as individuals and we as a society value, and trying to put a metric to it so that we could quantify them. And we often put monetary metrics because people can identify with them. But we're not really focused on money ultimately. We're really focused on values for individuals and values for society. So this is just a little example I give to, actually I teach a few courses on economic evaluation, and to the students to just frame it. So when you think about things that you value, how much would you pay to enjoy a day at the beach, right? So on an accounting exercise, you'd only count about the prices you'd pay, right? Your parking, the sunscreen, renting an umbrella kind of thing. And those are the accounting issues you need to account for if you were doing the accounting exercise. But as an economist, we want to think about value. So we want to consider the value of a fun day at the beach, right? What is it worth to you? And then what it costs you as well to think about the net gain from that day at the beach. There might be some parking and sunscreen, umbrella, but the value may be much more than that, just the direct cost that you incur, so that there's a net gain for you having that day at the beach. And that's the difference between accounting and economic. We're really trying to put value to the things that as individuals in society we really value, even if they're intangible. Health-related quality of life is not something that can be readily monetized, but we try to in our exercise because that's a critical aspect of preventing work injuries and illnesses. So our reference year, as I mentioned, is 2015. So we're looking at all workplace injuries and illnesses in these 5 countries: Finland, Germany, the Netherlands, Poland, and Italy. And then looking forward, what are the long-run impacts of those injuries that happen in the calendar year 2015? So this exercise can be done for every year following the one we're doing. And a number of countries such as Australia, Singapore, I think New Zealand as well, have started to do these exercises on a periodic basis. So just some background, we're not the first to do this. A number of people have been adding to this literature over time and expanding the methodologies as well. Heinrich might be somebody people might have heard about when he first coined the idea of thinking about direct versus indirect costs, where the indirect costs are often seen as being substantially larger. They often use the iceberg metaphor, where you only see a little bit of the direct costs, the healthcare costs, but a big part of those costs are below the surface, which are the indirect productivity type costs. The Health and Safety Executive has been doing a lot of good work in this area as well. We've borrowed some of their methodology around some of the costing components we're looking at. Safe Work Australia has done this exercise, I think, 3 or 4 times over several periods since the 2000s. New Zealand has also adopted some of that methodology. Lee has done similar work in the US, looking across different industries, different sectors and occupations, different categories of work injury and illness. The ILO is doing work. Singapore has adopted the methodology by Safe Work Australia kind of thing. So we're adding to a whole history of methodology that's been building up over time and trying to bring new elements to it as well, which I'll point out as we go forward. So where are we at today? So despite all those studies that I mentioned that have been published and are adding to the literature, there hasn't yet been a lot of effort to standardize these methodologies and identify a way to go about doing this computation so that we can compare across countries, so that we can compare over time within a country kind of thing, and have a uniformity of how these methodologies work. So there's a real benefit in trying to standardize these methodologies, and that's part of our contribution, our work with the EU, is trying to identify methodology that the EU can use across all the countries to do some comparative work and then continue to use those methodologies over time. So lack of uniformity of national level data is another problem too. We really struggled to find comparable data across these 5 countries, and you'll see some of the hoops we went through to actually make it comparable to varying degrees of effectiveness. And then the methodology, it has to be standardized too. There's 2 key approaches, both of which we actually undertook in our study. There's what we call a top-down approach, which I'm not going to speak to at length today, but that was one of the methodologies in our paper, and then the bottom-up approach. And the main distinction is that with our bottom-up approach, the emphasis of what I'm going to focus on today, we really take granular level data, the number of cases of work injuries and illnesses by age and sex and across different kinds of injuries and illnesses that arose in calendar year 2015, and build up the different cost components and aggregate it up to the total societal level burden. Whereas a top-down starts the other way around. You have some aggregate numbers and you just divide out and you get a per case costing from some national level aggregate data. I'm not sure if that's completely clear, but the granular approach, the bottom-up approach, is much more nuanced and detailed, and you can add new layers of, as you develop methodologies to compute different types of impacts. Whereas the top-down really uses like GNP numbers and divides GNP by the number of injuries and illnesses to get an approximation of the cost per case. So lack of uniformity of national level data collection. So this is one of the key things we struggled with. Just inconsistencies in the way different data are collected in different countries. Some of them are administrative data, so the programs that administer, say, workers' compensation collected in a certain way. Others are survey data and collected in yet a different way. There's a lot of underreporting we were struggling with, and I'll speak to that to some degree here to give you a sense of how we've tried to adjust for it. And underreporting varies by country for a variety of different reasons, given their social safety net, their history, their programs that are in place to collect this data. So we had to address that differently and think through which countries might have higher levels of underreporting than others and how best to adapt the numbers for that, to account for that underreporting. So lots of different issues that we had to deal with. Another one is how the systems pay for different types of aspects of work injury and illness costs, like healthcare, insurance, wage replacement benefits. The social safety net programs are different in each of these countries, so we've had to adapt where we get the data and how we account for what's not covered by some of these programs. And then one of the things we also did was we tried to identify the cost per stakeholder. We looked at the worker and the cost that they incur, the employer, the cost that they incur, and then the system and what costs they incur. And that obviously varies by the nature of the social safety net program in each country. Am I okay in terms of? I told Sarah to remind me if I speak too softly. I'm a very soft-spoken economist. Okay, so lack of standardization of the economic burden estimate. So there's lots of differences in those studies. I mentioned that history of this literature, and it's been evolving. We focus on the bottom-up approach, as I've mentioned, but even what cost components to consider in these studies is sometimes an issue. You know, healthcare is obviously one most people would think to include because it's a direct cost. How to deal with output and productivity impacts is a whole world unto itself, which I will get to only at the surface probably. And then health-related quality of life. I really think it's critically important that we include health-related quality of life measures in these studies. But historically, for some reason, they haven't, which I find extremely odd because the whole purpose of occupational health and safety and prevention initiatives in workplaces and in industries is because we value health and life. And yet not having those measures in these studies has been the norm, unfortunately. So I think in the past we've missed out on a large part of why we do this and a large part of the actual impacts that matter the most. So we've put large efforts into including this into our study here and other work we're doing in this area as well. So the approach we've developed, we did a study on mesothelioma and lung cancer from asbestos exposure, which has been published, which helped us get our feet wet, I guess, so to speak, to get a sense of how to build up these costs from the bottom-up type approach. Lee was a really good precedent for us because he did a similar approach, but didn't include the health-related quality of life component in his work. Safe Work Australia also was a really good precedent for us, and HSE, we drew a lot on their methodologies too for some of the components that we had to build up at the micro level. So we're just building on other people's work and adding new layers to it as we had opportunities to do so. So just some high-level assumptions and related factors. So I mentioned that we're doing incidence cost approaching, only looking at the new cases from 2015 using a bottom-up approach. The three large buckets of costs that we were considering were direct costs, which are healthcare kind of related costs, indirect costs, productivity ones, and then the intangible, the health-related quality of life costs. There's lots of little pieces in each one of those that we had to compute individually, but those are the kind of high-level categories. And as I mentioned, we considered lifetime costs for cases across all of the categories. And then some of the things we tried to do to advance it, we included presenteeism. Very few studies have tried to build in that component. Health-related quality of life, I think we're one of the first group to do that. And then out-of-pocket costs, to just name a few of the kinds of iterations of new things we're trying to add to our computations. So I'm going to give you one of the key results of our findings first, but I want to test you to think of which country do you think has the lowest cost of work injuries and diseases as a percentage of their GDP? These are the 5 countries we were looking at. So anybody have and Cam, you can't answer because you know the answer to this. You've read the report. But people who haven't read the report, any first guesses of what you think would be? C. The Netherlands would be the lowest? And why do you say that?
I say D.
You'd say D. Poland would be the lowest. And why do you say that Poland?
I don't know. But it's maybe data.
Okay. Just because it wouldn't be the real answer. It would be by default because we didn't have the right information or accurate data. Okay. And you think the Netherlands because they're very good at prevention? Okay. Well, I would buy that one more than the bad data because we did lots of good adjustments to account for underreporting. Okay. But there's lots of factors that build into this. But
someone said Finland.
Finland. Oh, all right, Finland. Okay, that's even better maybe. Finland probably even doing better prevention than maybe the Netherlands. Okay, well here's the answers of what we found, okay? And we tried to make these bubbles to be the size of relative to each other kind of thing. So as you can see, Finland is the answer at 2.9% of GDP, right? Netherlands is closely behind with Germany, right? and then Italy's after that, and then Poland actually is the worst from GDP. But this is just as a percentage of GDP, so there's lots of things that go into that number, right? Their GDP might be lower too. Industrial mix might be different as well, kind of thing. So there's lots of factors that bear on it. They don't necessarily mean when you see a higher or lower number that they're better or worse at prevention. There's lots of other issues that come into play that determine that number. But so that gives you just a sense of where we're at with the 5 countries that we were looking at. There's much more detail we'll get into before we get into how we constructed these numbers. So our structure for direct costs. So we're looking at workers and the families to figure out how much they would be incurring in terms of those costs. Employers' share, and then we're looking at the systems and public sector share across both direct, indirect, and tangible. And then we aggregate up to the societal levels to give all of these together, kind of thing. Dropping out things that are transfer payments for sure, but so some of the worker costs might be offset by, say, wage replacement benefits that they receive from some insurance program, but that might be a cost that the employer incurs, so they kind of drop out. But so the summing across to the societal level shows the net impact across all of the different stakeholders. These are just high-level categories across the 3 key stakeholders we're looking at, and trying to attribute them to particular their categories, whether they're direct, indirect, and intangible costs. So some of this will obviously bear on the types of social safety net programs. Workers and their families might bear more in countries that have more modest social safety net programs. In countries with more robust ones, they'll incur less of those costs. And depending on the nature of those insurance programs, whether it's paid for the public sector or by the employer, there'll be some play between those two as well, who covers the cost of some of the key impacts. So this is our baseline work injury counts from 2015. That was our starting point for identifying the number of cases that had been documented from various data sources that are referenced here. So we can see the count and also the percentage of the total. So we tried to categorize them by I guess a proxy measure of severity, how many days were lost. So because days lost obviously requires wage replacement benefits, their person's not being productive, so there's lost productivity involved in that. So no days lost, 1 to 3 days lost, and more than 3 days lost, and then we have fatal cases at the end. And so we can get a sense just of the number of cases and the percentage distribution across those different levels of severity. And as we can see with Finland, actually, they have the highest proportion that are in no days lost, so would suggest somehow that the severity of cases that do arise in Finland are less severe than ones, say, in Poland, where there's only 10% of them are with no lost time, and 84% are more than 3 days lost, which would suggest that either they're more severe or people have more of a tendency to take time off work when they have a work injury. So then we had to do some adjustments, right? So we weren't happy with just taking those raw numbers because we knew that underreporting may vary by country. For fatal cases, we're going to assume that gets reported, right? It's hard to avoid reporting a fatality, or hopefully in most of these countries. But we had to adjust for the non-fatal injuries for Poland and Italy in particular, because we had good grounds from previous studies that there was quite a bit of underreporting in those 2 countries. So we used ratios of fatal to non-fatal from other countries to adjust for the underreporting in those 2 countries. And then we did some sensitivity analysis around those adjustments using other countries as the baseline for that adjustment. So we started with Germany as the ratio from fatal to non-fatal to do those adjustments for Italy and Poland. And then we considered the Netherlands and Finland and used their ratios to adjust Poland and Italy's underreporting. But we didn't change the baseline counts for Germany, the Netherlands, and the Finland, because we had evidence from previous studies that their reporting was quite robust. So this is the adjusted estimates for work injuries and illnesses that we came up with then. So here the main difference is with Italy and Poland, where we've adjusted for underreporting of non-fatal injuries. And then the disease underreporting is even a bigger issue. As we all know, that's a big issue in most countries. A lot of diseases are long latency. They don't manifest until people are older, sometimes even into retirement. That's a big issue with the asbestos related mesothelioma and lung cancer studies that we were doing earlier on that I mentioned, that lots of those manifest in people when they're well past retirement. So they just don't get reported as work-related injuries or illnesses. So we really struggled with how to adjust for some of these underreporting issues with non-fatal and fatal diseases. So non-fatal diseases, we looked at the reporting of compensated and non-compensated cases, for certain categories of diseases. And for fatal diseases, we had some case counts from IHME from 2015 that were based on attributable fractions. And these are the categories of diseases that were identified through attributable fractions. So we're drawing on studies that have been done to attribute certain fraction of the number of identified cases in the population data that are attributable to work-related exposures. To make that adjustment for underreporting for work-related fatal and non-fatal diseases. Do you have a question?
Yes. Grace was wondering about on slide 19.
Slide 19.
I would have to look at it to provide context. So A and B, Grace, she wants to know about double counting.
Okay.
But maybe you can answer this one for now. Also, was training and retraining of staff and return to work included in the cost?
Okay, so I'm supposed to repeat the question. So was training of staff and return to work included in our computation?
So training, retraining, and return to work.
Okay, so we included what we described as adjustment cost for the employer, which sometimes they also described as friction cost. So when somebody's off work, you have to replace the worker. We accounted for that. And then if people return to work, we had some assumptions about their levels of productivity upon return to work in terms of presenteeism until they got back up to speed. If people had permanent impairments, we assumed that they had a certain level of reduced productivity for the remainder of their lifetime. And then a certain fraction of people with permanent impairments never returned to work. The employer had to replace them, so there's replacement costs. So we tried to account for as much of that kind of friction and adjustment costs at the employer level as possible, and then also consider the productivity impacts at the societal level as a separate exercise. And I'll actually get into a little bit of that later on as well. So hopefully there'll be more clarity once I get to that slide.
Okay, and there's the question about double counting. I'm assuming, Grace, you mean that the share of the healthcare cost isn't counted also from direct costs as well as indirect costs?
Sometimes, as I mentioned about transfer payments, I'm not sure if that's exactly what they're getting into in terms of double counting. So I already mentioned the example of wage replacement benefits. So you may not be working, so you don't get your income from your employer, but you might get wage replacement benefits. So that's an offset to that. Those wage replacement benefits are paid for through the insurance program, possibly, that employer pays for through premiums that they pay. So really, the employer's negative, their insurance cost is offset by a worker's positive, that they get wage replacement benefits. They drop out of the picture when we aggregate across society. So we're really only looking at the true impact or resource implications, not transfer payments between different stakeholders in the system at the aggregate level. But at the individual level, worker level, employer level, we do want to account for those, because we want to know what are the costs to the worker, what are the costs to the employer. Okay, we were. Okay, so now we're going to get into the sausage making thing that the economists talk about. It gets messy, right? All the details of how we do our computations for each of the components of the costs. So, and we had to make a lot of assumptions as we go along, because we're really looking at country level phenomenon, so we might have some insights from studies that have been done at the micro level, but we really need to make broad assumptions and broad adjustments to each of the categories of costs that we're looking at. So injuries with 3 or fewer workdays lost, we considered a nominal healthcare cost of €100. We didn't know what kinds of costs they might incur in terms of a visit to a healthcare professional, but not actually taking much time off. But we obviously realized that there's some costs involved, because they wouldn't have been documented as a work-related injury or illness if they didn't have some costs incurred that some insurance program had to cover. So a rule of thumb we use is €100, right? Injuries with more than 3 days lost. We had some good data from Italy, actually, that we really relied on for injuries with more than 3 days lost in terms of their healthcare costs. And then we prorated it for other countries because it was the best granular data we could get. Work-related diseases, we began with some data from Germany and then estimated costs for other countries using a similar approach as above, using healthcare indices, relative healthcare indices across countries to adjust the healthcare costs you'd expect to see in one country compared to another based on relative expenses in the different systems. We also consider out-of-pocket costs, so we estimated the percentage of costs, these costs based on the public healthcare services. We didn't have good data on out-of-pocket costs, so we made just some assumptions that it's a small fraction of the direct costs incurred by the healthcare system. That's an area that's an ongoing piece of work that several economists that I know of are trying to develop and build up better to get a good sense of what costs aren't covered by the system that consumers, injured workers, people with health conditions, what do they have to spend out of pocket to cover the things that aren't covered by the system. Informal caregiving, that refers to family members, community members that might have to take time off work or divert their energies from other activities to help take care of a person who's injured or ill at home and needs some caregiving and aren't able to do things that are domestic things themselves, so they get a family member to substitute for them. So we wanted to put a price on that as well. That's obviously an impact that affects the community, the family, and has value to it. So we're looking at some assumptions around how to identify the values of the time use as well as the value of that time used in caregiving, and just summarize it there. Looking at different lengths of time people are off work. So and would obviously, if the people are off work for a longer period of time, we're assuming that there's more informal caregiving being provided by the community members for that person. Output and productivity losses. This is a key indirect cost that I mentioned earlier on. We use something that I describe as the human capital approach. It's a terminology that's used by economists. And essentially what the human capital approach does is looks at how much time you're off work, whether it's temporary or long-term, permanent, and multiplies that time off work time by the wage rate of that individual. So you're thinking about if it's a permanent impairment, the person never gets back to work because they're unable to continue in their employment. They have a lifetime of lost productivity from that point of injury onward till standard retirement age. If it's a short-term absence, a week, it would only be a week's worth of productivity loss. So we're using the human capital approach because that's lost to society permanently when people are off work and come back to work eventually or don't come back at all. That's a long-term loss. Some studies focus only on the adjustment costs to the employer, thinking, well, the person eventually gets replaced. And that's fine for the employer's perspective, but since we're taking a societal perspective, we want to think about, well, what does society lose as an aggregate? So those people are no longer working, no longer productive for a short period of time or for a longer period of time. That's a loss to society. So we want to really capture the total human capital aspect of that. Cases with less than 1 day lost, we didn't assume any productivity loss here because they go back to work almost immediately. Cases with less than 6 months lost, we assume that they return to work without any change in their long-term productivity. If it was more than 6 months lost, we assumed that there was some permanent impairment that resulted in a productivity loss, a fraction of which we know would then be lost permanently, and some till age 65, and then some people did get back to work, so we assume some adjustment to their productivity capacity when they do get back to work. And then finally, fatal cases, the losses are assumed to obviously endure till standard retirement age. And then home production is another key part of the indirect cost. So if you're injured or ill, we're assuming that, and off work, we're assuming that you also aren't able to do things around the home. So those activities need to be substituted with other people's time or purchases of services from, some service market for domestic services. So we assume people off work are not able to do things in the home. For permanent impairment and fatalities, that home production activity is lost for the remainder of their lifetime. For people who do go back to work, obviously it's a transitional thing. So we used data on time spent on home production from different surveys across these 5 countries. It varies for men and for women. It's also age specific as well, so we did adjust for both sex and age because the time use in the home varies. And then we just use that times a wage rate for those kinds of domestic services to estimate what the value of the lost home production would be. And then presenteeism. So this is one of the new iterations we've added to our study as well. So you're all familiar with the term presenteeism. This is when you're at work, your health may be compromised, so you're not as engaged and not as productive. And many studies have found that these costs are even more substantial than the absenteeism costs. So we wanted to make sure we accounted for this in some way. So presenteeism costs are considered for all non-fatal cases with at least 1 day to 6 months off work of lost time. In cases with more than 6 months lost work time that went back to work. So presenteeism obviously happens only when you're at work. So only people who go back to work would have presenteeism upon return to work if they're not fully recovered. And for in some cases, it happens even before the absence. So particularly for diseases, because they're longer latency, the onset might happen, and before you actually take time off work, your productivity is compromised. So we considered presenteeism before and after return to work for diseases, but only after return to work for work injuries. And we're just drawing on precedents from Schultz's study for this. And then finally, employer adjustment costs. This is sometimes described as friction costs. So, the expenses related to a worker absence that an employer might occur to replace the worker temporarily or permanently if they don't come back to work. These are real costs that an employer has. There's a learning curve when a new worker comes on board, so they're not as productive. There's recruitment, hiring kind costs, onboarding type costs. So these are real costs that an employer incurs that we need to account for in our computations as well. So sometimes they're described as production disturbances. So like thinking about the production process has been disturbed by the fact that there's a work injury illness and somebody in that production process is off work, and that person needs to be replaced with somebody else who may take some time to get up to speed. And then there's some administration costs assumed as well to recruitment, hiring, and onboarding of a new worker, as well as administration costs of addressing that work injury illness claim activity that has to be dealt with. And then the final one we put in, this is something we've been building into most of the recent studies that we've been doing, is looking at health-related quality of life impacts from work injury and illness. For temporary and permanent disability, we used multipliers based on severity. For fatalities, obviously, the person's remaining life expectancy has been curtailed, so we can look at standard quality-adjusted life year profiles of the population as a proxy measure of what that person would have had as a quality of life over the remainder of their standard life expectancy. So, and then we had to put a price tag on it, because it only matters if we can monetize it and build it into our computations of a total economic burden. So there's a broad literature that takes different approaches on how to monetize quality-adjusted life years. You're all familiar with quality-adjusted life years constructs from the health technology assessment field. It's a metric that was developed actually at McMaster University to identify, I guess, morbidity levels, cross-sectionally and over time as well. So a quality is a year in perfect health. So you can scale a morbidity level of a particular person's health profile from 0, which is considered death, to 1, which is perfect health. And so most people fall somewhere between that 0 to 1 paradigm. And you can look at each type of health condition that arises from a work injury or disease and scale it between the 0 and 1 to understand what the decrement in their health is attributable to that work injury or illness. And then, so we can measure the qualities using that quality-adjusted life years and then monetize it using some kind of price price weights. We drew on some precedents from NICE, a UK organization that does health technology assessments. They use £30,000, which we translate to 41,000 euros. It's a modest amount. If we asked people their willingness to pay for an extra year of perfect health, they more likely say something in the hundreds of thousands of dollars. And the average willingness to pay that I've seen in the most recent literature is around $180,000 Canadian. So this is a very modest price weight that we're putting on it. Oftentimes, the healthcare system has a rule of thumb, a policy value that the system's willing to pay for new technologies that improve health profiles with different innovative treatment paradigms, and their willingness to pay in terms of the policy arena is much lower than people's willingness to pay. So this NICE value is more about the health technology field in the UK and what the healthcare system in the UK is willing to pay for improving people's health through new technologies. So I think we're underestimating the true value of health-related quality of life from preventing work injury and illnesses. So the results in terms of case counts of work injuries and diseases. So we can see here, just after we've done all of our adjustments, how many non-fatal and fatal injuries and how many work diseases that are non-fatal and fatal. From there, we can then do our aggregation across those three buckets of direct, indirect, and intangible costs to compute the total economic burden for these 5 countries. And so here are our results, I guess estimated in different ways to give it kind of a context. We can think of each of those categories in terms of millions of euros. It makes it hard to compare because each of those countries are different sizes, so they'll have different numbers of work injuries and illnesses. They have different industrial mixes. When we look at percentage of GDP, as we looked at earlier on, maybe it gives you some sense of the relative proportionality across countries adjusting for their size, with Finland being the lowest and Poland being the highest. Per case costing is another way to look at it too. So how much does each case cost the system in each of these countries? So in the Netherlands, healthcare costs are higher, labor costs are higher, so we see a very high rate for the Netherlands compared to, say, Poland, even though Poland has the highest as a percentage of GDP. And then per employed person might be the most appropriate way to look at it, because then you can think about what does it cost the labor force overall per person who's in the labor force. It's lowest for Finland and then highest for Italy. So just slicing in different ways to give it some texture and relative comparability across these 5 countries. I'll take a pause here. People can look at that, and if you have any questions about how to read it, how to interpret it, what it actually means.
Sorry, Emile, did you say that this is being published? Has it been published?
There is. The report is available on the EU OSHA website, both a summary version of it and a long version of it, and we've recently submitted the work as well for a peer-reviewed article to a journal, but that hasn't yet been published. This one? Yeah, so we think about the size of the labor force and how many people are in the labor force. How much do these work injuries and illnesses cost each person in the labor force, right? It's the societal level cost, but we think about, well, for each person working, there is a cost of 2,500 euros in Finland because we have work injuries and illnesses, where it goes up to 4,500 euros in Italy. So it helps you scale it and make it comparable. The comparability issue is really, really critical, because they're rolling out these methodologies across Europe, and the whole purpose of this exercise is to see what countries are doing better or worse, then maybe trying to dig it down and think about why, but then also help monitor and evaluate over time, so these countries are planning to redo these exercises on a periodic basis to see if they're making improvements in terms of their occupational health and safety systems. This is just proportioning it out by different direct, indirect, and intangible costs. It's a different way of framing it to think about, how much of it is healthcare, the direct cost, how much of it is productivity, how much of it is health-related quality of life. And as a proportion, that scales out differently as well, quite dramatically differently between different countries. As we can see, the intangible costs are the highest component in Poland, where in some countries most of the other countries it's the indirect, the productivity component that's the largest kind of thing.
A question about the previous slide, were the costs per year, per employed person per year?
Yes, these are reference here 2015. So these are new cases arising in 2015. So they will happen each year, right? So this is like an incidence cost for this one calendar year. So if the same number of injuries and illnesses happened in 2016, you would expect to see similar costs in 2016 as well. So these are enduring periodic costs. Okay. And just looking at per case costing and per employee costing, just to give a sense of the relative differences across countries. We can see Finland and Italy really high on a per case cost, but in a per employee cost, it's Italy that's the highest. So just slicing in different ways so we can get a sense of the relative comparisons across these countries. What are we doing time? Okay, we're almost right. So, okay, here's another skill testing question. What country do you think has the highest proportion of costs borne by workers?
Poland.
Okay, and why do you say Poland?
I'm assuming they have less protection.
Okay, so less coverage through social safety net programs. Kathy, you seem to agree?
There are more intangible costs
as well. Okay. Well, let's see how. Anybody disagree? Any counter arguments for?
Some are saying Finland and the Netherlands.
Finland and the Netherlands. Okay, because are they able to give us some details?
Because they didn't cite the reason why.
Okay. Okay. Just a guess.
Yeah.
Okay.
Because
Okay.
they pay. I'm guessing.
Yeah,
countries will pay more.
More, yes, exactly. But if the social safety net program is a critical difference across these countries that we need to take into consideration, and which we tried to do here. So if we look at the proportion of workers, is this yellow or ochre color in the bottom, we see Poland is the answer. And probably for the reasons Linda and Kathy are suggesting is that the social safety net program maybe aren't as robust, so more of it comes out of pocket, out of the workers' own losses, and less compensated through transfer payments through insurance programs, disability insurance programs, and wage replacement benefits that are received through workers' compensation. I think so. That gives you a sense of the distribution across different stakeholders. Really critical as well for these countries to know, which countries have better, more robust social safety net programs and cover the costs of workers as much as possible, kind of thing. As you can see, in all of the countries, the worker pays the most, right? A lot of it is the loss of health-related quality of life. It's not necessarily direct expenditures for like out-of-pocket costs, and the large loss of this loss is the health-related quality of life losses. So, and then what we want to do once we kind of did our methodology and computed these numbers is just do some robustness checks. We sometimes describe it as sensitivity analysis, really trying to understand if our assumptions might unfold differently than our starting point assumptions, would the numbers look wildly different? And if yes, what would they look like? So we tried to do some estimates with different assumptions and different input parameters for some of these numbers. Key ones obviously are the ones like attributable fractions, identifying how many cases there were of work-related diseases was a big struggle for us. And then thinking about what are the lower and higher bounds of some of these estimates when we do these sensitivity analysis. I won't get into this in a big way. There's a lot in the report that's online. But this just gives you a picture, a snapshot for Finland of some of the different scenarios we tested out. And the key one, obviously, as I alluded to, was disease incidence scenarios. What are those attributable fractions to identifying the number of cases that are attributable to work-related exposures? It has a huge bearing. The quality of life monetary value obviously is another big one because that's a big component of the losses at the worker level. discount rate, I'm not sure if you know that, but there's interest rates we use for just bringing future flows of resources down to the 2015 reference year. If you use a different interest rate, obviously that'll adjust for future values being larger or smaller in present terms, kind of thing. We did these for each of the countries. We call these, I think it's hurricane tendon diagrams, tornado, that's it, tornado ones, because we try to kind of stack them up to see which ones are the bigger ones that have bigger bearing on the numbers that we see.
Question of clarification. Earlier you showed the incidence from 1 year, then the costs per case are lifetime costs.
Yes. So. Yeah. So the cases we're looking at are reference year 2015. So how many work injuries and illnesses do we see in 2015? But those work injuries and illnesses have impact on those people's remainder of their lifetime in some cases. So we want to account for all of the remainder of their lifetime impacts and bring it down to the reference year, right? Because in the following year, there'll be new cases, again, with lifetime costs. So we need to account for the full impact across all future years. But that's different than accounting for them in, we aren't doing what they call a prevalence study, looking at all existing cases from all years. We're only looking at new cases in a particular year. Okay, so assumptions about incidence counts of work injuries and diseases are the most influential parameter. Obviously, diseases with long latency periods are often not reported very well, and fatalities as well, so often get excluded in work disease counts. So, whatever assumptions we make there will have a big impact on those costs. So results provide insights into the possible true range. Our point estimates are built on a lot of assumptions, and we know that there's probably a confidence interval around that we should be leery of, that our point estimates aren't the true value necessarily. So we really want to be conscious of what that range might be. So in terms of the reasons around the variation of GDP, we talked a little bit about that. Sector structure is a key one too. Some of them might be more heavily into the high-risk sectors of mining and construction and forestry, whereas others might be more administrative type functions. So whatever that sectoral distribution is in countries will obviously bear on the true inherent risks in those countries. Practices in particular sectors as well, so the prevention activities that are invested in might bear on it as well. And then the economic situations in labor markets as well. So what are the wage rates and the values for people, time, and other resources that are being impacted as a result of work injury and illness? Underreporting is obviously a key thing that we talked about. Some costing uncertainties. Healthcare, I told you we started off with Italy and Germany and prorated it for other countries. I was actually surprised at how hard it is to get good healthcare data in Europe. And I was really surprised about Germany. I thought they would have really, really great, robust data collection repositories that we could draw on. But it was a real struggle getting healthcare data from all of the countries. Data on permanent disability and productivity loss was another thing. We had to do a lot of stylization around, and so the other thing we're conscious of, just the different data sources and really accounting processes might vary as well. So really put a close eye to making sure that we were comparing apples to apples and oranges to oranges, because we weren't always confident that that was the case, and thinking about, do we need to make adjustments if they're not comparable.
A question that occurs to me is, how much did you capture of mental injuries or psychological stress-related, harassment-related, that kind of thing?
We did try to account for them. I don't know how good a job. The data we had was, from the national level data repositories sort of thing, and some of them we'd have to do some adjustments. Amir, do you recall if we used attributable fractions for mental health? We just took the values that they provided directly. So I have a feeling we probably underreported it then. Yeah. Okay. So just some conclusions. We were focusing on both conceptual and applied aspects of this exercise. We're trying to advance the methods. As I mentioned, it's being rolled out. I think Austria has reused our methods and have finished their computations, and there are a couple other European countries that are halfway through using these methodologies as well. We've had some conversations with them. They've even given us some suggestions about the next round of how we can improve on our numbers as well. So it's a very interesting dialogue with the countries as they roll it out across the EU countries. they really provide a basis for undertaking the economic evaluation, which hopefully will be the next stage of some of this work, people using the case costing to evaluate the merits of different prevention efforts. And then I'm hoping we can do this study in Canada as well to see how we compare to the EU. I think that's a really important next iteration for our efforts, given that we're based here in Ontario and Canada kind of thing. So I would like to see us do this work here in Canada. And then we're just adding to this list of methodologies and computations, and hopefully leaving our mark by bringing in some new dimensions to the consideration of different impacts across society. So I have a few minutes for questions.
Thank you, Emile. We have 5 minutes for questions. Obviously, you didn't value those minutes at the start of the presentation.
I answered a lot of really good questions from the audience.
Are there any questions from the audience? We have 5 minutes that we have. Cindy.
How much does it differ if you do the top-down analysis versus the bottom-up? And do most people in the past use the top-down?
Good question, actually. We did some comparative. Yeah. Oh, yes. I have to repeat it. So, how much does it vary between the top-down and the bottom-up? And do people mostly use the top-down approach? So I'll answer the second part of that question first. Most people use the top-down approach because it's a really little bit simpler process, because all you need to know is the injury counts and disease counts, and then divide it out by some aggregate number like GMP. Comparability is a challenge because there's less of a conceptual underpinning for the top-down approach. We are really trying to think about deconstructing all of the known impacts that have been documented across different stakeholders and valuing them and aggregating them up. So it's much more theory driven, whereas the top down is a kind of a back of the envelope calculations. So even if they were comparable, it sometimes might be just an accident, I think, because you're not taking into consideration the full range of impact. You're really just looking at some summary measure that's, for convenient purposes, helps you get some quick numbers that you can compare then across countries. GNP doesn't really reflect the impacts that we were talking about. GNP is current year's productive output in a society, and it doesn't really relate to anything that relates to long-run losses at the individual or societal level as a result of work injury and illness. So the comparability issue, even though people have asked that question, I'm less inclined to think that there's a reason that they should be similar, or even if they were, that they would be meaningfully similar. If you understand what I mean. I think they're used for a whole different level kind of a consideration, usually at regional level. So a number of these studies have used the DALY's computations. I'm not sure if you're familiar with disability adjusted life years. It's another way of measuring health deficits that was developed by the World Health Organization. It's a bit the converse of qualities. Rather than qualities is what the quality adjusted life years that you do have, DALY's is what you've lost from perfect health. And it was constructed to do regional comparisons across very disparate regions such as Africa with Europe, to think about disability associated losses to human health and also productivity across different regional areas. So they've used those DALY's for the top-down approach in our study. It was the Dutch group who really focused on developing those computations in our study, and then we compared the two. And I don't recall exactly. Do you remember, Amir? Were there anything close to what we had found?
Actually, much bigger.
Theirs are much larger.
Yes. Okay,
so they're bigger numbers, and I'm not sure if that's just an accident of the way they're computed, or whether there's something you can really draw from them. As I mentioned, the GNP method of dividing out by GNP doesn't really get at what we're trying to get is what are the impacts on society from these work injuries, and also they're just a high-level summary measure.
Questions online?
A few people would like to take a crash course on economic evaluation from you.
Okay. I'll roll them next week.
Emile, I have just one question, if I could. So, as you went through it today, there's a lot of different assumptions that are made across the way, and sometimes the same value is given to every injury in every the same injury in every country. When you present that aggregate figure, do you think policymakers understand all of the assumptions and nuances behind it, or do they just want a number?
Okay, good question. I'm not sure. Different people have different levels of economic savvy and might drill down into some of these reports. Others might trust, the precedents that we've built on. And if you just summarize where you've drawn from, the Australia studies from Safe Work Australia is a key precedent. Like Singapore has adopted that, HSE has adopted that. We try to follow on what they're doing and build on that sort of thing. So it's the precedents that makes a really big difference. We're not just taking this, from a black box and reinventing it. So there's not a need for everybody to drill down on that. If they're comfortable with what's gone by in previous studies, they know that we've just added these new layers on it. So I would guess that a lot of people don't get into the weeds as much as I do, or Amir, and that they probably don't need to, because we're really building on what others have done.
Comparability is, I guess, important rather than the absolute number.
The absolute number is important too. It depends on the decision you're confronting, right? So the information here, it has many layers. I mean, I've just really glossed the surface. I mean, you can stratify this by sector, by type of disease or injury, by age bracket. So depending on the question you ask, is it about a prevention issue? What areas should we focus on in terms of sectoral level? What age brackets do we need to really focus on in terms of who has the highest burdens in terms of, over the life course? It could be at, the systems level. Are we covering enough of the cost that workers incur as a result of work injury? So there's lots of questions that can be asked of the data, and you might drill down on a specific component of it. So the absolute matters too, because we're trying to add in as many of the known impacts as possible so that these are really reflective of the true cost to society. So the absolute matters. The relative matters too, because if some other country's doing better, we want to know that, and then we want to know why, right? So that part matters too.
Just have one more question on that.
The economic burden as a percentage of GDP is really low in the United States compared to the European countries. Why do you think that's the case?
Good question. We haven't completely deconstructed our work comparison to others. Amir, do you recall what they don't have qualities, the health-related quality of life measure. So a lot of the earlier studies that don't have that, as you saw, it was a big fraction. So that's a big part. We've also included the presenteeism, which most studies haven't as well. We've included home production, which a lot of them don't. So there's a number of layers that we've added of known impacts that just haven't been part of the measurement paradigm with the older literature. So I think that's part of what's driving it too. So it's a reflection of us being more fulsome of the full set of impacts that are incurred.
Okay, so that's...
Thanks very much. I have to leave, sorry.
Thank you so much for coming.
We're about to wrap up.
Okay.
Thank you, Emile.
Thanks, all.